I'm holding an anterior cruciate ligament, but that's not what we're talking about now. Time to talk about some white blood cell disorders. So we're really focused this talk on white blood cell malignancies, also known as cancer. First one we're going to talk about is lymphoma. And I choose to do this because I think it's typically the one that people are most comfortable with. A lot of people have heard this term before. To break down this word, I want to let you know that the suffix oma, O-M-A, indicates a mass. That's important. So when you have a patient with breast cancer and you hear breast carcinoma, there's a mass within the breast tissue. A lymphoma indicates a mass within the lymph nodes caused by malignant lymphocytes. And the discussion here is going to really focus on how those lymphocytes became malignant. Now, to talk about the genetic changes of a lymphoma or leukemia or multiple myeloma, I first have to just kind of revisit with you kind of normal A and P of a hematopoietic stem cell, shown here kind of on the far left, and how it matures into different blood cells. So this hematopoietic stem cell, through its differentiation stages, and there are many, but initially it will undergo just two options. It will either grow up into a lymphoid progenitor cell or a myeloid. Just two options, that's it. Lymphoid progenitor cells will then grow up to become full-grown lymphocytes. Myeloid progenitors will grow up to become every other blood cell in the bone marrow. All right, that's it. Let's say, for the sake of argument, I'm trying to figure out what's what and where is where, that those lymphoid progenitors take on the correct genetic alterations or chromosomal alterations that would produce a cancer cell. Those cells are still very young in their differentiation. They're still trapped in the bone marrow. And if those cancerous changes take place to that lymphoid progenitor, what the clinical presentation would be is an acute lymphoid leukemia, or an ALL. All right? In the myeloid progenitor cell, if that cell takes on the correct genetic chromosomal changes for cancerous behavior, that cell is still housed in the bone marrow, hasn't been released out to the blood yet. Right? In that setting, you will have a clinical presentation that shows acute myeloid leukemia. So in either of these two, the green box or the red box, those are both very young cells in the process of differentiation. I like to think of them as teenagers, not fully mature. Go back up to the lymphoid cell line. Let's say the teenagers are allowed to mature even further before they take on the right genetic changes to become a cancer cell. All right? Let's say that happens. almost a mature B lymphocyte, almost a mature T lymphocyte, or a mature plasma cell, which is just a B lymphocyte. At that point, you'll have manifestations that are congruent clinically with a lymphoma, which is what we're about to talk about. So, focusing on leukemia, it's really important to conceptualize in your brain that a lymphocyte, whether that's a B lymphocyte, T lymphocyte, that there is a very multi-step maturation or developmental process that these cells have to go through to become mature lymphocytes. And in so doing, they can make genetic or chromosomal errors along that way. Some of those errors may potentiate cancer, in this case, a lymphoma. So if you are basically starting at I'm going to try to point at the top of this picture, and you're kind of working your way progressively down, at each one of those stages, if cancerous genetic changes erupt, you have a different lymphoma. And I include this picture to try to illustrate to people that are studying kind of the pathology of different lymphoma or lymphocyte diseases, why there are so many different types. People that are naive to lymphoma think, well, it's Hodgkin's or it's non-Hodgkin's lymphoma. That's it, man. No, there's over 50 different subtypes of lymphoma out there, and each of them are genetically distinct. Why would there be all this genetic chaos in lymphoma? Don't know if you remember this or not from your A&P class, but it's worth revisiting. When the cells of our immune system are maturing, they have to undergo something called VDJ recombination. And VDA recombination as the name kind of implies, taking chromosomes apart and then reconnecting them at different places. This is done naturally and correctly all the time, and it's what allows our white blood cells to create a personalized white blood cell arsenal just to you or just to me. It's basically our natural response to the germs all around us. Unfortunately, there can be errors involved in this as well, and some of those errors are thought to be what contributes eventually to the development of a malignant lymphocyte. Secondary to that, or alongside that, is the theory of viral integration into lymphocytes. We know that some viruses, A, infect lymphocytes, and B, integrate their viral genetic material into the genetic material of the lymphocytes themselves. Epstein-Barr virus, human T-cell lymphoma virus, some of the herpes viruses will do this. And because it alters the genetic material of the lymphocyte itself, it can do so in such a way that potentiates growth irregularity, aka cancer. Now, one real interesting pathologic finding in Hodgkin's lymphoma, especially, but other lymphomas as well, is a transcription factor that is dysregulated or uncontrolled. Now, to kind of understand NF-kappa B, nuclear factor kappa B, and transcription factor, you really got to dip back into A&P and go back to cell physiology, cell signaling, and how transcription occurs. All right, so go revisit that and then come back. Did you do it? That's great. So normal transcription is a tightly controlled process. In roughly about 50% of Hodgkin's lymphoma patients, there's an inflammatory transcription factor called NF-kappa B that is transcribing genes for survival, proliferation, invasion, the production of new blood cells, which is called angiogenesis, and the spread of lymphoma cells, called metastasis. And it's doing so all the time in a very uncontrolled fashion. So, in this particular setting, the normal cell signaling that would turn NF kappa B on, NF kappa B is an inflammatory transcription factor. Inflammation should be temporary. You should cut your finger, it inflames, it heals up, and then it turns off. In about 50% of Hodgkin's lymphoma patients, NF kappa B is just constantly saying, whoa, we're going to transcribe all these healing genes and grow new blood vessels. And that's not good. That is not good at all. Here's a kind of a cartoon schematic of normal NF kappa B way over there, and then say Hodgkin's lymphoma related NF kappa B right down here on the right-hand side. Normal NF kappa B exists in a cell signaling cascade. Again, you learned about this, if you remember it, in physiology. It's hard though, got to admit, so if you forgot, it's okay. So normal NF kappa B is an inflammatory transcription factor. And when there's, say, local cell injury, let's just say I cut my finger. Woo, I cut my finger. That trauma then elicits white blood cells to the area. White blood cells will communicate with cell signaling factors, and one of those is tumor necrosis factor, or TNF. TNF acts as what's called a ligand. Remember that from A&P? And what ligands do is they communicate. They help communicate to other cells by binding to proteins on a cell surface. TNF binds to a TNF protein receptor on the outside of a cell. The TNF receptor then communicates into the cell to a kinase called I-kappa B. I-kappa B then changes its form to turn into NF-kappa B. NF-kappa B translocates to the nucleus to basically transcribe pro-inflammatory genes. When the healing job is done, when inflammation is done, that cell signaling process should turn off. In roughly half, maybe a little less than half of Hodgkin's lymphoma patients, we have shown a dysfunctional NF-kappa B pathway. And I won't give you all the molecular mechanisms because we are not the biochem students. But this is a fascinating area of research, and it's also an area of therapeutic research to find out if we can utilize pharmaceuticals to rein NF-kappa B back in. So as NF-kappa B is kind of going, oh, we're, grow and divide, grow and divide, grow and divide, you're getting more and more lymphocytes and other inflammatory gunk inside your patient's lymph nodes. And that's what leads to the clinical presentation of Hodgkin's and some other lymphomas, where the lymph node is then enlarged. Now, Hodgkin's has a fairly predictable clinical presentation. It's most often in the cervical or supraclavicular lymph nodes, but on rarer occasions, it can occur in the armpits or also within the chest itself. And there's been more than one occasion where I've had patients who have gone and gotten a chest x-ray. There's a mass on the chest x-ray, and they're thinking they have lung cancer. It goes and gets worked up, and it turns out they actually have a kind of rare presentation of Hodgkin's lymphoma. Because Hodgkin's lymphoma often involves, as I mentioned, dysregulated NF-kappa B, some of the other clinical manifestations can be somewhat inflammatory or feverish or sick, and kind of that flu-like symptoms in nature. And collectively in the lymphoma world, we refer to these as B symptoms. Weight loss, night sweats, and fever are your three common B symptoms. And when I say night sweats, I mean drenching the bed sheets. I got to change the bed kind of night sweats. In your lymphoma patients, for Hodgkin's lymphoma specifically, there will always be a biopsy to work up a lymphoma. You got to take out a lymph node, slice it up, make slides of it, examine under under a microscope, and see what you got. A characteristic Hodgkin's lymphoma cell is called a Reed-Sternberg cell. And it's called this because the cell itself, when you look at it under a slide, the nucleus will have this, it's called a bilobed appearance to it. And clinicians used to say, oh, it looks as if it has owl eyes. And that's why I have a little cartoon of the owl on this slide. So a Reed-Sternberg cell has this very characteristic bilobed nucleus. But that's kind of a more antiquated way of suggesting that this person has Hodgkin's lymphoma specifically. Science has gotten way better at being distinct with regard to what type of lymphoma there is because there's so many out there. So the workup has to really include something called immunophenotyping. Let's break that word down. We know what a phenotype is, right? We've done A and P. We know that our phenotype are the genes that we actually express in any given cell that we're looking at. And our phenotype is different for the different cells of our body, all right? My fingers do not express or have the same phenotype as my cardiac myocytes. They're expressing different genes because they're doing different things. Immunophenotyping is simply the process of looking at cells of the immune system and seeing what proteins or genes they are expressing. That's it. That's it. And what we're really looking for when we do immunophenotyping are the cell surface proteins for the lymphocyte that we're suspicious of. Here's why. Of all the B cells and T cells that you got floating around, each one of them will have a distinct fingerprint of what are called clusters of differentiation, CD markers. See the little cell I've got kind of down in the corner of the picture? Imagine all those little cell surface proteins serve as little flags to tell our body what type of lymphocyte that particular cell is. So one subtype of B lymphocytes might express CD12, 13, and 45. Another subtype of B lymphocytes might express on their cell surface CD 112, 95, and 80. What it does is it creates this kind of ability for us to, if we look at those proteins that are expressed on the cell surface, we can tell exactly what kind of lymphocyte we're dealing with. It's a more specific way of figuring out what type of lymphocyte we have, and therefore what kind of treatment is good for that patient. The process is called immunophenotyping, and it basically creates a protein fingerprint to help identify white blood cells, specifically lymphocytes, based on their cluster of differentiation profile, CD profile. You know, when it comes to contrasting Hodgkin's and non-Hodgkin's lymphoma, I'm shying away from that from a pathologic perspective because I really want to focus in on is the concept of the genetic alterations that occur during VDJ recombination and viral integration. And that can occur in any lymphoma. When you see patients with lymphomas in clinic, you know, that the workup in terms of, you know, what's actually going on, what was the pathologic change and things, might actually start with questions regarding their clinical presentation. You kind of almost work backwards. The first question in the clinician's mind may be, hey, do I have here an aggressive non-Hodgkin's lymphoma or an aggressive lymphoma or a lymphoma that's expressing itself or behaving in an aggressive way versus one that is sleeping or indolent. That's kind of the clinical term for a sleeping lymphoma. I bring this up for prognostic purposes. People that are showing signs of an aggressive non-Hodgkin's lymphoma need to be treated and need to be treated relatively quickly. Indolent lymphomas are sometimes so slow growing and slow in their proliferation that they're actually not even sensitive to chemotherapy. Medical science is, especially cancer medical science, lymphoma included, is always looking for new drug targets, things that we can create synthetic antibodies for, administer the antibody to the patient, have that antibody bind to the specific protein that it was programmed to bind to, and then that antibody flags other cells in the immune system to destroy that cell. Here's a real-world example of that phenomenon. Many lymphoma cells express or overexpress a cluster of differentiation cell surface protein called CD20. There's a drug called rituximab that is basically made to target CD20 specifically. You can see in the picture that little purple antibody, that's a rituximab monoclonal antibody. That's what MAB means at the end of rituximab. So a patient would get an infusion of rituximab, go into the body, and its only destination is CD20 positive cells. So lymphoma cells that overexpress this are going to be more sensitive to the antibody-mediated destruction that rituximab allows for. When patients are treated with lymphoma, that's not risk-free. Pathologic circumstances can result from lymphoma treatment. One of the most noteworthy is something called tumor lysis syndrome. When, let's say a patient, just use a clinical example. Say a patient has 10 million lymphoma cells, and they're going in for their first cycle of chemotherapy. Right? They get that infusion, and the cancer therapy or chemotherapy goes in and lyses 5 of the 10 million malignant cells. 5 million cells lysed in 10 minutes. Can you imagine that that's a lot of cellular debris to clean up in a relatively short period of time? Your body does a great job of cleaning stuff up, but sometimes you overwhelm the system and the body just can't clean things up on time. Tumor lysis syndrome is a phenomenon whereby so many tumor cells are killed so quickly that the intracellular debris that gets released can't be cleaned up fast enough. So phosphates and calcium bind together, forming calcium phosphate stones, can cause electrolyte imbalances for both phosphate and calcium, when they bind together, can cause kidney stones. Intracellular potassium that's suddenly extracellular can cause hyperkalemia, which can have cardiac consequences and cause disruptions in the heart and how the heart beats. Excessive nucleic acids break down to release into uric acids. High blood uric acid levels can also become uric acid stones and can also contribute to kidney injury. In addition to that, lactates can become collections of lactic acid, and your patient can become acidotic as well. Tumor lysis syndrome is something that is often anticipated for, but when it's not, it can be very challenging to to treat. And the acute kidney injury as a result of it may be permanent.